Respiratory Emergencies, Chapter 16. Now, in this chapter, we'll be looking at a review of the anatomy. We'll look at signs and symptoms and management of respiratory emergencies, which will include issues that affect the upper airway and issues that affect the lower airway. We will look at the anatomy, physiology, pathophysiology, and assessment and management of epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, chronic obstructive pulmonary disease. We'll be looking at environmental and industrial exposure, toxic gas, pertussis, cystic fibrosis, pulmonary embolism. We'll be looking at pneumonia and viral respiratory infections. Introduction. Patients often complain of dyspnea. Dyspnea is difficulty breathing. So this is going to be very common in the pre-hospital setting. So this is a common complaint. However, there are a lot of things that can cause dyspnea. So the patient often complain of dyspnea can be caused by many different conditions. Cause can be difficult to determine. So because multiple things can cause it, it can be difficult to pinpoint exactly what is causing the dyspnea. Let's review the anatomy of the respiratory system. The respiratory system includes all the structures that contribute to breathing, and that includes the diaphragm, the chest wall muscles, the accessory muscles of breathing, and the nerves to the muscles. The upper airway consists of structures above the vocal cords, the nose and mouth, jaw, oral cavity, pharynx, and the larynx. So the upper airway is the pharynx, the mouth, the epiglottis. These are important structures to be aware of. And the pharynx is the posterior portion of the throat. The epiglottis is a leaf-shaped cartilaginous structure that prevents anything that's not air from entering the lungs. And the larynx is an important landmark. So it's anything above the larynx is upper airway, anything below is lower airway. Important lower airway structures include the trachea, the bronchioles, and you have the bronchus, which divide into the main bronchi, and then the bronchi breaks down into the bronchioles, and at the end of the bronchioles, you have the alveoli. You also have a right lung and a left lung. The right lung has 3 lobes, the left lung has 2 lobes. And the reason for that is majority of the heart is on the left side. The space between the lungs is referred to as the mediastinum. So the space where the heart and major blood vessels are found is referred to as the mediastinum. The lungs have a membrane around it. So it has that membrane has an inner lining and an outer lining. And it is referred to as the pleural membrane. So the visceral pleura is directly attached to the lung tissue. The parietal pleura lines the lungs cavity. And if you look at this picture, you can see where the diaphragm is. The diaphragm has a dome shape when it is relaxed. So what you're seeing now in this drawing, the diaphragm is in a relaxed state. When the diaphragm starts to contract, it flattens out. Remember that. Now, principal function of the lung is respiration. And this is the exchange of oxygen and carbon dioxide. Air travels through the trachea into the lungs, to the bronchi, which is the larger airways, and the bronchi breaks down into the bronchioles, which is the smaller airways, and at the end of the bronchioles, you have the alveoli, where the actual exchange takes place. Now, the physiology of respiration. Respiration process, and it's really ventilation we're talking about at this point. So the respiration process has inspiration and expiration. One is active, one is passive. Oxygen, the active phase means that the intercostal muscles and the diaphragm contracts. The passive phase means that the intercostal muscles and the diaphragm relax. So inspiration is active. That's a phase where muscles contract. Expiration is passive. That's the phase where muscles relax. Oxygen is provided to the blood. Carbon dioxide is removed, takes place rapidly at the level of the alveoli. And there's a diagram depicting all of that. In the alveoli, oxygen passes into the capillaries. So if you look at this diagram, you can see that there are blood vessels wrapped around the alveoli. So you have pulmonary capillaries wrapped around it. And as air reaches the alveoli, oxygenated blood, as air reaches the alveoli, oxygenated blood, no, not oxygenated blood, sorry. As oxygen reaches the alveoli, blood that is deoxygenated is coming from the right side of the heart. And when it passes over the alveoli, it picks up oxygen. The brainstem senses blood carbon dioxide levels and regulate breathing rate and depth. Pathophysiology. So that's a quick review of the anatomy and physiology of the respiratory system. If you are still weak in that area at this point, go back to your anatomy and physiology lectures. Let's look at the pathophysiology now. Oxygen exchange can be hindered by conditions in the anatomy of the airway, disease processes, traumatic conditions, abnormalities in pulmonary vessels. Recognize the signs and symptoms of inadequate breathing and know what to do about it. Some patients have chronic carbon dioxide retention, low levels of oxygen, control breathing, use caution when administering oxygen. Now, if a patient has chronic carbon dioxide retention, that's not going to be a patient that is relying on the primary stimulus to breathe. That's a patient that is functioning off the hypoxic drive. And at this stage within the course, I expect you to know the difference between the primary stimulus to breathe and the use of the hypoxic drive. Once a patient is functioning off the hypoxic drive, it means their stimulus to breathe is low oxygen. That's what hypoxia means. It means low oxygen. Now, causes of dyspnea. Patients often have dyspnea or hypoxia with pulmonary edema. They can have it with hay fever, which is a mild allergic reaction. Pulmonary edema is fluid accumulation in the lungs. They can have pleural effusion, which is a small amount of fluid outside of the lungs. They can have obstruction of the airway. They can have hyperventilation syndrome or panic attack. It can be due to environmental or industrial exposure or drug overdose. So a lot of things can cause dyspnea. Dyspneic patients may have gas exchange obstructed. They can have damaged alveoli. They can have obstructed air passages. They can have obstructed blood flow to the lungs. They can have excess fluid in the pleural space. And there's a table that outlines the signs and symptoms of inadequate breathing. Spend some time and look at that when you're studying. Patients may also complain of chest tightness or ear hunger, common with cardiopulmonary disease. Pain can cause rapid, shallow breathing. Now, let's look at upper or lower airway infection. Infectious diseases may affect all parts of the airway. Some forms of obstruction cause dyspnea. The patient can have mucus and secretions obstructing the airway in major passages. They can have swelling of soft tissues in the upper airways. They can have impaired exchange of gases in the alveoli. So they can have mucus or secretion that obstruct the air passage. There can be edema or swelling. They can have constriction, and they can have fluid in the alveoli that interferes with the exchange of gas. Now, when we start to get to these levels, this is why it's very important that when you assess breathing, when you're assessing breathing, you look at rate, rhythm, quality, and depth. Because when a patient is having a breathing problem, you need to determine if it is a ventilation issue, an oxygenation issue, or a respiration issue. If your assessment is not thorough, then your treatment will not be appropriate. Now let's look at Croup. And when you're going through this chapter, you need to group them. So group the conditions that are going to affect the upper airway and group the conditions that are going to affect the lower airway. Now, croup is inflammation and swelling of the pharynx, larynx, and trachea. It causes stridor and a seal bark cough. And stridor is it's a high pitch wheezing type sound that you can hear without putting a stethoscope on the patient's chest, and it indicates that something is wrong with the patient's upper airway. Any patient that has a respiratory tract infection, if you're going to be giving them oxygen, give them humidified oxygen. So even if you start off with your dry oxygen in the field, once you get to your unit, put them on humidified oxygen. When a patient has an infection, they're going to become dehydrated. If they have mucus or secretions, it's going to, if it dries out, it becomes very thick and it's difficult for the patient to clear that. When you give them the humidified oxygen, it moistens the secretion. So it helps to loosen up the secretions, and sometimes they even cough it up. So remember that. If there is a respiratory tract infection, you need to give oxygen. Humidified oxygen is going to be beneficial to these patients. Do not manipulate their airways. So if you suspect that there is an upper airway issue, do not manipulate if it is not required. You can make the swelling worse. And Croup is significant for your pediatric patient based on the size of their ear passage. Now, epiglottitis. Epiglottitis is a bacterial infection which causes inflammation of the epiglottis. Children are often found in a tripod position and drooling. So the mouth is going to be open, they're going to be leaning forward, there's going to be drooling. Because it's a bacterial infection, they'll have a high fever. So bacteria cause high fever. Viruses don't cause high, well, some do, but Croup would not have a high fever. Now, keep the patient in the position of comfort. And just like with Croup, the patient will benefit from humidified oxygen. Do not manipulate their airway. So if it's not necessary, meaning you don't need to do any airway management, do not manipulate. So don't open them airway, say you want to look for siwa guan. If it's not necessary, you can make the situation worse. Now, respiratory syncytial virus. It's common causes of illnesses or illness in young children. It causes infection in the lungs and ear passages, right? It leads to bronchitis. Look for signs of dehydration, which is going to happen with patients with infection. So once a person has an infection, they're at risk for dehydration. If they have mucus or secretions being produced in the lungs or ear passage, if it dries out, it becomes thick and it's difficult for the patient to clear it and it can obstruct the airway. Treat the airway and breathing problems. Again, humidified oxygen is going to be beneficial to these patients. Bronchiolitis, oh, not bronchitis, it's actually bronchiolitis, so I'm mixing it up. So the RSV actually will lead to bronchiolitis. And once you see the term itis means inflammation. Once you start to think about inflammation, you're thinking about swelling, you're thinking about fluid leaking, stuff like that. And wherever the inflammation is, it can lead to an infection. So you're thinking about fever as well. It's a viral illness often caused by the RSV or respiratory syncytial virus, usually affects newborns and toddlers. Bronchioles become inflamed, swell, and fill with mucus. provide oxygen therapy, and frequently reassess. And bronchiolitis would be a lower airway problem. So let me just backtrack for a bit. So Croup is upper airway, Epiglottitis, upper airway, respiratory syncytial virus, primarily the lungs, can affect the upper ear passage, but it's primarily going to be a lower airway issue. Bronchiolitis, lower airway issue. Now, pneumonia. Pneumonia is basically not necessarily a bacteria. It can be bacteria, it can be viral, it can be fungus, but the issue is the patient has a lung infection, right? So bacterial pneumonia will come on quickly and result in a high fever. Viral pneumonia presents more gradually and is less severe. Now, any patient that has a respiratory tract infection, once there is drainage into the lower airway passages, again, if they become dehydrated and that mucus get thick and they can't clear it, they're going to develop an infection in that area, and that can lead to pneumonia. And it especially affects people who are chronically ill. Assess temperature and provide airway support and supplemental oxygen. Now, we primarily associate fever with infection. Just note that for your geriatric, right? For your geriatric patients, they can have an infection with no fever. And that's why in the previous chapter, I said to you that a medical patient can present with the typical signs and symptoms, and they can present with atypical signs and symptoms. So a patient with pneumonia and no fever would be atypical presentation. In order for you to pick up that it's pneumonia, your assessment must be thorough and your history taking skills must be immaculate. Right? Because I'll give you another example. I don't want to stray too much, but a patient with pneumonia can present with wheezing, and you can interpret that wheezing as the patient having asthma, but it's not asthma the patient have, because a patient with pneumonia, when they wheeze, it usually is on one side. It's not going to be bilateral, right? So it's specific to the infected area of the lungs. A patient with asthma, when they wheeze, it's going to be more bilateral and it's going to be on expiration. Now, a very important point for you to note is that not every patient that wheezes has asthma, and not every asthmatic patient will wheeze. Very important. So temperature regulation, provide airway support, supplemental oxygen. And again, I'm going to keep emphasizing this. Once you suspect any type of respiratory tract infection, whether it's lower or upper airway, humidified oxygen will be beneficial. Now, pertussis, we spoke about this in the last chapter, in the previous chapter. Airborne bacterial infection that mostly affects children younger than 6 years. Patients will be feverish and exhibit a whoop sound on inspiration after a coughing attack. Watch for dehydration, suction as needed. Now, these two issues, dehydration and mucus in the ear passage, is detrimental to a young pediatric patient. This is a nightmare. So you don't want a young pediatric patient to become dehydrated, and you don't want their airway to become compromised. So one of the primary causes of cardiac arrest or cardiopulmonary arrest in a pediatric population is going to be airway compromise. That is what kills them. So if you can fix their airway, you can save them, and you don't want them to get dehydrated. Influenza type A became a pandemic in 2009. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. May lead to pneumonia or dehydration. I'm supposed to know this like at the back of the hand now. Infection leads to dehydration and mucus clogging up the air passage. COVID-19, SARS-CoV-2, similar to the virus that causes the common cold. And y'all are COVID expert at this point, right? COVID experts and conspiracy theorists. Similar to the virus that causes the common cold, preferentially affects elderly, those living in close quarters with one another, and those with weakened immune systems. And I believe in the next update, they will have to change all of that because there are different variants now. Transmitted by aerosol droplets and airborne particles. Respiratory deterioration may occur rapidly. Tuberculosis, TB, we talked about this previously. Bacterial infection that most often affects the lungs can remain inactive for years. I spoke about the latent TB and I spoke about the active TB. And again, the patient, if they have inactive TB, they cannot spread it. So it's not contagious at that point. Once it becomes active, it becomes contagious. So if it's inactive, it can lead to active TB. So the patient requires treatment to prevent that. Patients often complain of fever, coughing for more than 3 weeks. They will have fatigue. They're going to lose weight. They're going to have a loss of appetite. Wear gloves, eye protection, and the N95 respirator at minimum. Again, let me emphasize this. If you're going to be wearing an N95, N100, or K95, or HEPA, the mask needs to be fit tested and seal tested specifically for you before you can put it on. You cannot just take a K95 or an N95 out of a pocket and put it on. They have to fit test the mask and give you specifically what matches your face so that the mask forms a proper seal. Now, acute pulmonary edema. And quite a few things can cause pulmonary edema. One of the most common causes of acute pulmonary edema is actually being exposed to chemical agents. So other things can cause it. Congestive heart failure can cause it. That's another common cause, specifically left side left side dominant congested heart failure. So the heart muscle cannot circulate blood properly. Fluid builds up within the alveoli and in the lung tissue, usually result of congestive heart failure, can be caused by chemical exposure as well. Most patients have a long-standing history of chronic congestive heart failure. In severe cases, a frothy pink sputum forms at the nose and mouth. Now, what is important for you to note? Regardless of the cause, you need to think about the patient presentation. So, what is the ABCs telling you? What is the history telling you for this patient? Lung sounds, very important to patients who are having respiratory problems. So if you don't listen to the lung sounds, you might not be able to pick up that there is fluid in the lungs. And if a patient has fluid in the lungs and all you're giving them is oxygen, that ain't gonna get the fluid out of the patient's lungs. They need more than just oxygen. They're gonna need something that can push that fluid out of the alveoli. As long as fluid is in the alveoli, respiration cannot occur. All right, now chronic pulmonary obstructive disease, or COPD. It's a slow process of dilation and disruption of the airways and the alveoli caused by chronic bronchial obstruction. Chronic smokers are at a high risk. So tobacco smoke can create chronic bronchitis. Now, COPD has two issues. So when a patient has COPD, they can have both, or they can have one that is more dominant than the other. So COPD can include chronic bronchitis, which is inflammation of the bronchi, or it can have chronic, or they can have chronic emphysema, which affects the alveoli directly. So bronchitis is a bronchi, it becomes inflamed, it swells, fluid leaks, and the air passage becomes narrow, so the patient has difficulty removing air from the lungs. Not all the air is removed from the lungs, so they start to retain CO2 because of that. For emphysema, the damage that is created by the chemicals from the smoke removes the surfactant of the alveoli, and your alveoli need surfactant for it to maintain elasticity and allow air to pass through it. So when the alveoli loses that elasticity, it collapses and no air exchange occurs. So that's your chronic bronchitis and your emphysema. The patient with chronic bronchitis, they tend to, that is with chronic bronchitis as the dominant issue, they tend to be overweight. They tend to have a productive cough every 3 months over a 2-year period. They are blue or gray. They have a blue or grayish color because of the retention of the CO2. And they gain weight because they don't move around a lot, because if they move around, they start to get shortness of breath. The person that has emphysema, chronic emphysema, they tend to be slim. So they are slim because they use a lot of energy to breathe to keep the alveoli from collapsing. They start to produce more red blood cells, right? So their blood also changes in its viscosity. So emphysema is the most common type of COPD, loss of elastic material in the lungs, specifically the alveoli loses its surfactant. Causes include inflamed airways, smoking. Most patients with COPD have elements of both chronic bronchitis and emphysema. So they can have a combination of both, or they can have one that is more dominant. but both of these conditions will lead to chronic obstructive pulmonary disease. Now, the term chronic means it occurs over a period of time. Acute means sudden. Remember that. Now, if you look at this diagram, right, you can see where there's a mucus plug. The one in the middle, you can see where the air is being trapped. So the patient doesn't have an issue getting the air in. The problem is going to be when they need to get the air out because it pins shut when they try to exhale. So not all of the air is coming out. And that's how they start to retain carbon dioxide over time. So eventually, a patient with COPD will ultimately end up relying on their hypoxic drive to breathe because of the chronic retention of CO2. Still on COPD, patients with pulmonary edema will have wet lung sounds. Patients with COPD will have dry lung sounds. And you can hear wheezing in a COPD patient. Can be easily confused with congestive heart failure. Treat the patient, not the lung sounds. So again, with your medical patient, you have to be thorough with your primary assessment. You have to be thorough with your history-taking skills, and you manage the patient's presentation. So you have to think about everything. Don't think about just one thing. Think about everything. Now, asthma, hay fever, and anaphylaxis. So result of allergic reaction to inhaled, ingested, or injected substances. It can also be absorbed. In some cases, allergen cannot be identified. In some cases, there is no identifiable allergen. Now, asthma is a reactive airway disease, and the trigger is going to be an immune response, immune or inflammatory response. So asthma is acute spasm of the smaller air passages, the bronchioles, and three things will occur in a patient who is having an asthma attack. This patient will have constriction, so they're gonna have airway constriction. That's the first thing that starts to occur. So let me back up a bit. First, an allergen enters. There is a trigger. Something triggers the asthma attack, right? Doesn't necessarily have to be a allergen, because some persons can have asthma attack because they are too anxious. It can be from exercise. It can be from the cold. There are a lot of triggers, but something triggers the attack. In the initial phase, the patient starts to have spasms. It's an immune response. So they start to have spasm in the air passage. That's the first thing, bronchoconstriction. Then, because of irritation, they start to get swelling or edema. They start to get swelling of the air passage. Because of the irritation, mucus starts to be produced. So three things will occur in your asthma patient: bronchoconstriction, swelling, and mucus production. So these three problems will need to be addressed. Not all will be addressed by you, but these three problems will need to be addressed in the hospital setting. What you can address in the field is the bronchoconstriction. But if they have passed that phase, then you cannot fix it. So if they're in the phase where they're having swelling and mucus production, a bronchodilator is not going to work. Ventolin is not going to fix the problem. Okay, so asthma is acute spasm of smaller air passages, bronchioles associated with excessive mucus production and swelling of the mucous membrane. Asthma affects all ages, most prevalent in children 15 to 17 years. Adults can have it as well. Produces characteristic wheezing. However, again, yes, it can produce wheezing, and the wheezing is going to be on expiration initially, right? So, but if it starts to get really bad, they can actually produce the wheezing on inspiration, but it's going to be more commonly on expiration. However, if the ear passage is significantly constricted, so what is causing the wheezing is, let me see if I can find my pen. Hold on. So what is causing the wheezing? This is the ear passage, right? So this is the ear passage, and then you have the swelling and inflammation in the middle. So you have swelling and inflammation in the middle. So the ear passage becomes very narrow. So what is happening is that when the patient exhales, it opens up and air can get in. When the patient inhales, it opens up and air can get in. But when they need to exhale, it pinches shut. It's too narrow. And as the air is being forced, so they have to actually force the air out. As it's being forced out of the lungs, out of the ear passage, it creates a vibration. And that vibration is what causes the wheezing. Now, if it is too constricted or too much swelling is there, you will not hear any wheezing. So you're not going to hear any movement of air in that area. So again, not every patient that wheezes has asthma, and not every asthmatic patient will wheeze. So what I always tell students is, if you hear wheezing, don't think about asthma. Think about constriction. Just think about bronchoconstriction at that point. Don't try and figure out if it's asthma the patient have. You have heard constriction. What do you need to do about that constriction? Patient need a bronchodilator. Okay. All right, hold on. Let me go back. All right, there we go. Hold on. Now, asthma attack may be caused by allergic reaction. It can be allergic reaction to foods or allergens or severe emotional distress, exercise, respiratory infections. Now, hay fever causes cold-like symptoms, and think of hay fever as a mild allergic reaction. So it's mild. Allergens include pollen, dust mites, pet dander. An anaphylactic reaction is a severe allergic reaction. And because it is so severe, in its severity, it will affect the ear passage and it will affect the circulatory system because of excessive histamine production, which we covered this in the shock chapter. Hold on, let me backtrack. And if you're suspecting an anaphylactic reaction, the only thing that will reverse that is epi. So epinephrine is the first line treatment, right? So it's epi, O2 as needed, and O2 would come before the epi. or both can be given in combination depending on the patient's presentation. Then antihistamines can be considered. Antihistamines would not be something that EMTs would be giving to an anaphylactic patient. That's more paramedics or advanced, depending on where they are working. Now, spontaneous pneumothorax. A pneumothorax is the accumulation of air in the pleural space. And the pleural space that we're talking about here is that membrane. So the membrane around the lungs that have a inner lining and an outer lining, there is a space between these membranes. It's called the pleural space. So air can collect into that space and cause the lungs to collapse. It is referred to as a spontaneous pneumothorax when it is caused by a medical condition. Now, patients with chronic respiratory problems, chronic asthma, chronic COPD, they have been having the COVID for a while. Once it's chronic, they're at risk. So the lining can rupture spontaneously and air collects and the lungs start to collapse. So pneumothorax, again, is the accumulation of air in the pleural space, most often caused by trauma, may be caused by medical conditions. And once it's a medical condition that causes the pneumothorax, it is referred to as a spontaneous pneumothorax. Still on spontaneous pneumothorax, occurs with lung infections or weak lungs. Patient becomes dyspneic. Breath sounds may be absent on the affected side. So they may have absent or diminished lung sounds on the affected side. Pleural effusion. This is the collection of a small amount of fluid outside the lungs. You tend to see this a lot in patients who have lung irritation, cancer patients, common in cancer patients, cancer of the lungs, congestive heart failure patients. Upright position eases the pain and discomfort. Obstruction of the airway. Patient with dyspnea may have mechanical obstruction. In unconscious patients, obstruction may be the cause caused by aspiration or vomitus or tongue blocking the airway. If patient was eating just before dyspnea, always consider foreign body obstruction. Now, pulmonary embolism, this is something we also looked at in shock last week. A blood clot that circulates through the venous system. The circulation cut off partially or completely. So there's a clot that develops in the venous system and it travels to the right side of the heart. So it enters the right atrium, enters the right ventricle, and then goes up into the pulmonary artery, and it can block both pulmonary artery, or it blocks one side. That's your pulmonary embolism. If it blocks both pulmonary artery, the patient immediately goes into cardiac arrest. You're going to go into cardiac arrest. Now, signs and symptoms include dyspnea, that's difficulty breathing, tachycardia, tachypnea, varying degrees of hypoxia. They will have cyanosis, bluish discoloration of the skin. And you're going to look at the lips, you're going to look at the palms, the mucous membranes. And this cyanosis may not improve even after you have given the patient oxygen. They can have acute chest pain. They can have hemoptysis. Hemoptysis means they are coughing up blood. And anytime a patient is coughing up blood, it tends to come from, or coughing up fluid, it tends to come from the lungs. When they vomit of blood, it tends to come from the digestive tract. Now, hyperventilation or panic attack. This is overbreathing to the point that arterial carbon dioxide falls below the normal level. It may be an indicator of life-threatening illness. The body may be trying to compensate for acidosis, which is a buildup of excess acids in the blood or body tissues. So it could be that the patient is genuinely having a panic attack. They got some bad news or something occurred and they start to panic and overbreathe the carbon dioxide. So they drop the carbon dioxide levels and the pH drop too low. No, not the pH, not going to drop too low, sorry. The pH increases. When it drops low, it's acidosis. When it goes too high, it's alkalosis. And they can even lose consciousness as well. So it can be they're just having a panic attack. Or it can be there is some type of metabolic acidosis that is occurring within the body, like a diabetic patient, a patient in diabetic ketoacidosis. Acidosis is building up in their body, and the body has to find a way to compensate for that. And how the body compensates for acidosis is the body will increase the patient's respiratory rate to break up the acid into water and carbon dioxide, and then you exhale. Then the patient exhales the carbon dioxide. So it can be one out of the two. If you're not sure, use your partial non-rebreather if you're going to give oxygen. So we don't use the paper bag treatment to treat a patient that is hyperventilating. That is not done in the EMS profession, to the best of my knowledge. Now, I'm not saying that the paper bag doesn't work. If a person is having a genuine hyperventilation syndrome or panic attack, the paper bag will work because it's going to cause them to retain the CO2 and the breathing will gradually slow down. We do not do that in EMS because, again, the patient can be compensating for something, right? So the patient can be compensating for an acidotic state within the body. And if I have a patient that is compensating for an acidotic state in the body, and I give them a paper bag to rebreathe CO2, it's just going to make the acidosis worse. And you're going to have a more serious problem to deal with. So because of the drop in the CO2, the pH is going to rise and they start to develop alkalosis. So there's a build-up of excess base in the body fluids. The symptoms of a panic attack include anxiety, dizziness, numbness, tingling or painful spasms of the hands and feet. We call it carpal pedal spasm. So their fingers start to stiffen up and that make them start to panic more. Now, when you're going to give these patients oxygen, don't just put the oxygen device on them face. You have to make an attempt to calm them down. Mom, sir, need to give you some oxygen. I need you to control your breathing. No, I can't. Yes, you can. We're going to do this together. You're going to work with me. Work with me, man. You can work with me. So I want you to take a deep breath. Exhale, hold it until I reach to 1. I can't. Yes, we can together. We're gonna do it together. Deep breath. 5, 4. Not bad. You let it go early. Come again. So you work to calm the person down. Then put the device on their face. Don't make sense you put a mask on them face if they're not controlling their breathing. Now, environmental and industrial exposure. So pesticide, cleaning solutions, chemical, chlorine, and other gases can be released. Carbon monoxide, odorless, highly poisonous, produced by fuel, burning appliances, and smoke. Do not put yourself at risk. And let me see the time. We're going to pause here because we're going into the scene size up. So we're going to pause at this point